and Dr. Griffin, I know there are different therapeutics at different times, and I guess what really is, what should patients know, because they want to, obviously people want to stay out of the hospital.
Yeah. I mean, timing really matters with so many things, and particularly COVID. And we learned that over time. We did not know that a year ago. And so this has been an incredibly rapid, steep learning curve for all of us. So this is a first week antiviral therapy. We break COVID down into roughly two main stages. There's an early first week viral symptom phase that Diana was describing. You feel crummy, you've got a cough, trouble breathing, headache, fever. That second week, that's when the inflammatory phase triggers and people often end up in the hospital. This is an antiviral therapy that's critical to be given in the first week. So what you need to do is you need to reach out. You need to reach out to your doctor. If your doctor's not familiar, you got to keep reaching out. We love the support of Survivor Corps. You can go right to Survivor Corps and there's check boxes. Do I qualify? Am I 65 and over? Maybe I'm a little younger, but I've got some other medical problems. This is a therapy that a lot of people are eligible for. And basically we're saying, if you've got a 10% or higher chance of ending up in the hospital, you want to jump in on this therapy. And we're going to reduce that from maybe 10% of people going to the hospital, maybe 2% going to the hospital after this therapy. And the most exciting thing this week was that in the large phase 3 trial, the people getting monoclonal antibodies, nobody died.
Wow.
Dramatic effect.
Yeah, and I would add that, it is so important to get it early because it cuts down on that viral replication. So you just if you do not qualify under the rules at gotcovid.org, go. If you're, it's automatic if you're over 65, if you're under their various other, comorbidities or situations that will qualify you. But even if you don't fall into any of those categories, like I wouldn't fall into any of those categories, if I got COVID today, I would enter into one of those trials immediately.
And that's
Because at
what's
least then I would
interesting is
get a
on
chance
the
of getting it.
website, you have a way that you can enter all the different trials. There's all
Exactly.
different boxes.
100%.
All right, Dr. Griffin, it's there's two different makers, if you will. I'm not going to try to pronounce how to say everything, but let's talk about the difference between what we have. So we have Regeneron, which is two different monoclonals, and then Eli Lilly, which kind of did it a little bit differently. So talk to me about the difference between these treatments.
Oh, certainly. Yes. No one can remember the names. I feel like they did that on purpose.
Yes.
So the Regeneron cocktail made by the company Regeneron is two different of these antibodies. One comes from a humanized mouse, interesting enough, the Velocimune $120 million breeding mouse. I cannot afford to buy a pair. Regeneron can. And from a person who had COVID and made antibodies. The other approach is the Eli Lilly. They started with a single monoclonal called bamlanivimab. But then this week we heard that they also have their own cocktail with a second drug called atezolizumab. I told them put an L in there, called it a Tesla, and then it would sell better. But those are really the approaches, and they're not the only companies. There's other companies getting ready to get out there with data we're hearing about. So what we're doing is really looking at different areas, looking at the variants. I hate to talk about variants, and trying to decide in different areas what's the best treatment. In areas where we're not seeing a lot of variants, we're using the Bam because it looks like the data is really compelling. But some of the areas here in New York City, David Ho emailed me earlier this week saying, hey, we need to start looking at using more cocktails with the variant increase in our area.
And